So I'm going to talk about the $1 trillion idea. Can we reduce the cost of healthcare while improving care? There's this debate now in Washington and in the whole country with this false premise, I would argue a false premise, that in order to save costs, we have to trade that off by caring for less patients or somehow cutting care. I think we can cut up to $1 trillion a year while improving the quality of care, and it's not through a single payer system. So a quick background on me. I am an emergency doctor at NYU, and I practice, and I went to Cornell Med School. That's how I met these guys. I'm on the alumni board here. I did a business degree at Columbia. I've done a lot of disaster preparedness as part of the Ebola response team at NYU. And in my field, I created a set of guidebooks that are published by a not-for-profit organization called EMRA, and they're sent to every emergency medicine resident in the country. So it's what's made me known academically in my field. But perhaps most significantly, I'm one of the co-founders of MDCalc. MDCalc is the largest medical calculator and clinical decision tool reference. It's 12 years old. It's the site and app that has all of those clinical scores in medicine. Glasgow Coma Scale, CHAS-VAS score, et cetera. Things doctors use at the bedside to make clinical decisions. And it's now used by over 60% of US doctors each and every month. So that makes us the largest medical reference that's owned and run by physicians. We recently took over another evidence-based medicine website called VNNT, which stands for the number needed to treat. It's a statistical metric. Separately, I started a small pharmaceutical company. We have taken old medications and used them in clever ways to treat different diseases. And this reduces the cost of developing the drug and also reduces the risk for the patients. And we're doing this, or trying to do this, in multiple sclerosis, cholesterol, and post-op pain not using opiates. All right, this is going to be a little interactive. This is a quiz, and everyone has to vote on this. This is 2 separate questions. I'm going to ask you which one's the caduceus and which one's the correct symbol of medicine. All right, everyone has to vote in both of these, okay? So who thinks that this here is the caduceus? I'm expecting everyone to vote, so a lot of hands are going to go up. Who thinks this is the caduceus? All right, so the majority think this is the caduceus. Okay. All right, now the correct symbol of medicine. Who believes that this one's the correct symbol of medicine? About half of you. Who thinks that this is the correct symbol of medicine? All right, I would argue most of you guys thought this was the caduceus, and maybe 50-50, but a little bit more thought this was the correct symbol of medicine. Well, you guys were wrong. The caduceus here is this one with the 2 snakes and the wings, and that's also known as the wand of Hermes, and it's not the symbol of medicine, even though it's used in marketing as such. 1 staff, no wings, 1 snake is the staff of Asclepius, and that's the god of medicine, and that's the correct symbol of medicine. There's only 1 organization I see consistently getting this right. Anyone know? Or 2 organizations, actually. Oh, great, good guess. I did not plan her there. No, actually ambulances. Look at ambulances, they always have the correct symbol of medicine, and Blue Cross Blue Shield does too. But most others use the wrong symbol of medicine. So what is this symbol that we're using inappropriately for medicine? Well, Hermes, he's not the god of medicine, but he was the god of business, thieves, and war. Which brings me to my talk about healthcare and finance. And we spend a ton of money on healthcare. We all know this, right? Before Medicare 65, we spent about 5% of our total budget. And that's grown to about 18, almost 20%. You can see it leveling off here. That's Obamacare. $18 trillion a year, that's our entire budget in this country. Who thinks we spend more? Another vote. Everyone has to vote. Who thinks we spend more on defense or healthcare? Who thinks it's defense? Who thinks it's healthcare? 50-50. All right. We spend a lot of money on defense. It's $600 billion. It's going to go up to $650 billion with Trump, right? But we spend a whole lot more on healthcare. That's over $3 trillion, about 18%, 17%. That's more than the entire GDP of the continent of Africa. If it was its own economy, we'd be the 5th biggest economy in the world. We have 5% of the world's population, but we spend 50% of the world's spend on healthcare. So this is used a lot to say, God, we're spending so much on healthcare. We got to do something about it. And I'd argue all this spending isn't necessarily bad. We have to look at what works and what doesn't work. And what I fear in a single-payer system is that it misses America's unique place in the world in driving innovation. If you work for any healthcare innovation company, pharma, device, diagnostics, whether or not you're an American company or a European company, you legitimize the investment because at the end of that business plan, you're selling your product to the American market. And that represents 50% of that. And that legitimizes your investment in innovation. So if we went single payer and decreased our spend, and 20 years passed, we wouldn't know what we were missing, right? We wouldn't know the innovation that we didn't bring along. So what we have to do is look backwards. What innovation happened in the last 30, 40, 50 years? And there's a ton of it. Just look at medical imaging. Ultrasounds during pregnancy. That one thing has revolutionized infant mortality. Vaccines, I put this in here because we have to aggressively fight this anti-vax movement. Vaccines have removed terrible diseases that people don't even have to think about. And the fact that they don't have to think about it, I think is an issue sometimes. We discovered things like, mushrooms have this lovastatin thing that can mess around with your cholesterol and reduce your risk factors. Pretty neat. But we have to be careful when we study drugs. These are the children of thalidomide before we had as tough regulations by the FDA. If we're not careful, we can make dangerous drugs. And you cannot talk about innovation without mentioning cancer. Cancer has gone through several revolutions in the last 20 years. First with the Gleevec, the tyrosine kinase inhibitors from about 20 years ago, which in a much more targeted way aimed at some cancers. And then even more recently, in the last 3 years, immunotherapies. There are metastatic melanomas and metastatic lung cancers that were death sentences 3 years ago that shrink away because of immunotherapies. This is all really amazing. So what kind of waste am I talking about? And there's this Harvard Business Review that I'm kind of quoting this $1 trillion idea, right? They say that if you looked at all of the wasted money in healthcare, we could save about a third of it, which adds up to about $1 trillion. And I'm going to focus now on some examples of clinical waste, so you know what I'm talking about. I'm going to go through 4 examples. One's in screening, another one's in hospitalizations, because it drives a large portion of healthcare, right? Appropriate hospitalizations versus treatment at home, then in testing, and then in treatments. Case 1, to screen or not to screen? That is the question. Prostate cancer screening. This has been in the news a lot. Who's heard about prostate cancer screening and the whole thing with it? Okay, so good. Some knowledge here. 1 in 6 men are going to get prostate cancer in their lives. It's a lot. Look around this room. 1 in 6 of the men in here. And 1 in 6 in them, so 1 in 36, will die from that prostate cancer. That on its surface makes us want to think, we have to screen for this. It's common. We can catch it early. We should be doing something about this, right? So what is the screening mechanism we use for prostate cancer? PSA. So you go to the doctor, you're 50 or 55 or whatever it is, and you go to the doctor and you get this PSA test. And from the surface, this doesn't look dangerous, the blood test. Costs a doctor visit and a blood test, maybe a couple $100. But it actually can be dangerous. And you have to think about this. Tests that don't seem dangerous can have a side effect because of what we call false positive rate. The test might come back positive even when you don't have the disease, driving you to do the next step in the path, which at some point will have a side effect. Okay, so even tests that don't seem like they have side effects do eventually because of false positive rates. And for PSA, you know what it is? When you get a positive PSA, you need to get a biopsy of your prostate. And one of the ways they do that is a transrectal biopsy, an ultrasound-guided biopsy, where 12 times a needle punctures through your rectum into your prostate and grabs tissue. Very expensive, not very fun. And 6% of these patients come back with an infection. And one of those 6, they visit me in the ER. And I'll tell you, when I see that diagnosis or the chief complaint on the screen pop up, fever after prostatic biopsy, I'm running to the bedside. I'm putting large bore IVs in and antibiotics, because that can be gram-negative sepsis. And that's a high mortality, nasty disease. So there's real bad side effects that happen when you start getting PSA tests. So I would hope there's some benefit, right? We're saving some lives on the other side. Let's look at that. So they've done really nice reviews of this, organizations such as Cochrane, et cetera. And they've looked at 1,000 men over the age of 50 and followed them for 11 years. And they said, all right, if we don't screen them, it turns out 210 men will die. And about 7 of those 210, 1 in 36, that's your 1 in 36, will die from prostate cancer. Now, if you start screening those patients and go down the PSA and that whole path, you have some other side effects that happen. About 160 men are going to get phone calls saying, hey, you might have cancer. You have to come back in for this biopsy. 20 of these are going to be diagnosed with prostate cancer and receive unnecessary treatment. And after all of those reviews, if you talk to people 3 months ago, the best reviewers would say, not one person is saved. Not one person is saved. All that cost and expense. Have you guys heard what's changed in the last 2 months? So this bothered a lot of the folks in the field. Definitely bothered the urologists, because this pays them well. But it also, I think, goes against the American mentality of more must be better. And so they started doing reanalyses of the same data sets. And one of the analyses showed a benefit. And this is what the Annals of Internal Medicine, who published that, tweeted. Reanalysis of evidence suggests PSA screening may significantly reduce the risk for death. You know what bothers me about this? This is in the Twitter sphere, whatever we call it. Significantly means something different to me than it does to the public. That means statistically significantly. But to the public, that means meaningful, right? And it's inappropriate for them not to use that word there. So let's look at how meaningful of a difference they found after they had to dig a few times. And the U.S. Preventative Services Task Force changed their recommendations. They're actually in the midst of changing this now. They said still, the men over 70, we still give a grade D, which means we recommend against screening. But in this range of patients, we'll give a grade C. Grade A is we strongly recommend. Grade B is we mostly recommend. Grade C is we're not so sure. Talk to your doctor. There might be some situations where it makes sense. Because in the end of the day, 1 out of 1,000 of those patients seem to get reduced prostate cancer, despite all those other side effects, right? So there's a couple issues here. When you keep on looking at analyses, remember when you look for statistically significant things, you're looking for something that has a p-value such that there's only about a 1 in 20 chance that it happened accidentally, so you can rely on it. When you keep on looking at subgroups, if you look at 20 subgroups, guess what? You'll probably have one that randomly hits, and then you're going to say, hey, it's statistically significant. That's called p-hacking. A little bit of that's going on here, right? We've done several reanalyses. And then in addition to that, turns out that even a larger amount are benefiting from in the all-cause analysis, which the all-cause of death analysis, which they actually didn't do the analysis in the paper, but about 2 to 5 patients do better there. So there's probably some correlation thing that we're not picking up on. Are these patients going to the doctor more, or are they healthier in some way, even if the randomization was partially there? So we have to be careful with these results. And then there's something that's being ignored, which is green tea. And I'm not a naturopath at all. I'm an evidence-based medicine guy. But it turns out that there's reasonable evidence, green tea and the stuff in green tea that you can put into pills reduce the risk of prostate cancer significantly. Some studies show up to 90%, but there's no money in it, and it's hard to study. So maybe we should be giving more green tea and stop doing all these transrectal biopsies. All right, example number 2 is hospitalizations. That's something I have to make a decision of as an emergency doctor very often. And a great example of that is pneumonia. Do pneumonias get admitted to the hospital or sent home? Depends, that's right, depends. And what did it depend on? And it used to be on clinical judgment of the physician. And now we have some better, objective, evidence-based medicine scores, and this is what MDCalc does. We don't create the scores, but we make it understandable by the physician, like the PSI, pneumonia severity index, that help judge if a patient should be inpatient or outpatient. Third example, Natasha Richardson. You guys remember her? I hear about her every day. That's that actress who fell, hit her head, didn't go to the ER, and then died from a head trauma. Everyone's coming to the ER saying, I'm worried. I hit my head. I heard about that story. Actually, the story usually is they go to a city MD, or their kid falls, they go to city MD, and they see a physician there, or a nurse practitioner, and they say, just to be sure, let's send you to the ER and send a note, get a CT. So they come to the ER and get a CT. Now, there's real costs there, right? Urgent care visits, a few hundred. You have to pay for the radiologist and for me. That's at least $500 for the two of us. The facility fee, we're getting a couple $1,000. But it's more than that. There's another side effect. What's the other side effect? Radiation, right? Does anyone know how much radiation a CAT scan is of the head? Actually, in terms of a chest x-ray, is a CAT scan of the head like 1 chest x-ray worth, 5 chest x-rays worth? It's 100 chest x-rays worth of radiation. That's 2 millisieverts. And that increases your chance of getting cancer, on our best guesses, because this is not perfect science, by about 1 in 10,000. So not huge, but there's a real risk there. We get a lot of CAT scans in the ER. So the question is, what's the benefit of all these CAT scans? And it turns out that only 1.5% of people that we end up seeing with head trauma require an intervention. That's neurosurgery for a bleed or skull fracture. And of course, the next question is, could that person at CityMD know a group of patients that they can reliably say, you are safe, you do not need to go to the ER, that reduces costs, that reduces radiation? It would be great to have such a rule, and that rule exists. This Canadian guy, Ian Steele, because the Canadian government spends a lot of money on this research, developed a rule called the Canadian CT head rule. And through large studies, he showed a clinical criteria. Clinical criteria means history and exam, nothing else, where you can reliably say to 70% of those patients, you're not going to get a CAT scan. And this is such a great rule that at most, and it's questionable that it's even this, you might miss 1 out of 50,000 clinically important injuries. That's way below that threshold of cancer, right? But still, doctors aren't using this nearly as well as they should. My last example is cardiac stents. We've known now for decades that cardiac stents, those are stents that go in the coronary arteries. Coronary arteries supply blood to your heart, the heart itself. Outside of an immediate ST elevation heart attack, where it does save lives, outside of that, when you have a partial blockage and chest pain, it has not shown to produce mortality. There's this great article in The Atlantic earlier this year, when evidence says no, but doctors say yes. Anyone see that article? My business partner was actually quoted in that because of the VNNT, that site we run. Essentially, there's this high-functioning Manhattanite who develops chest pain, goes to the ER, he doesn't have an immediate heart attack, and he gets diagnosed with this partial blockage thing. And he's smart, and he reads about evidence-based medicine on his own before he sees the cardiologist, and discovers that there is no benefit of stents, there is a benefit of medications and exercise and diet. And he sees the cardiologist and says, what do you recommend? And the cardiologist says, I want to put a stent in. He says, but the evidence doesn't show that. He said, go look for more evidence. So he went to a second cardiologist, and he said the same thing. What do you recommend? I recommend you put a stent in. But the evidence doesn't say that. He said, I know the evidence doesn't say that. I still want to put a stent in you. So he finally found the third cardiologist, which was an evidence-based medicine physician who agreed that the stent shouldn't go in, agreed with treating him with maximized medical, diet, and exercise therapy. So let's review how these decisions are made and how we're thinking about this. Now, physicians make clinical decisions, right? But it's not just us. There's the hospitals who create protocols. And there's the insurance companies who pay us for what we do. It's not just us making these decisions. And there's pharma companies and innovation companies that develop new treatments that could be evidence-based or not and push that out on us. And the goal here is to drive patients who would benefit from a treatment toward the treatment, but not those who wouldn't. You won't want to expose them to the risks and costs of that treatment, and vice versa. Those who don't benefit from a treatment, who do benefit from a treatment, you don't want to send them to not having that treatment. So in order to do this better, we need to create more evidence, do large studies like Ian Steele that get published in big medical journals. But in addition to that, we have to publish and do those reviews of those evidence and then create ways that a practicing clinician can understand that evidence and apply it at the bedside, which is ultimately the area that I'm very interested in, MDCalc and the VNNT does. And if we improve that, the goal is to have more patients who benefit toward the treatment and vice versa. This is the key of evidence-based medicine, improving care and reducing cost. So how do we make this change happen? First of all, I would argue we have to remember those creating evidence have to be good at math and statistics and running studies. They're different than the practicing clinician. I love this joke. So you must be P more than 0.05 because I failed to reject you. So this is the statistician, right? And it's very different than the clinician at the bedside who's a people person but might not be great at math and statistics and understand these studies. These are not the same kind of person. We have to support both of them. We have to put those types of researchers. Canada's great at this. And a lot of the clinical rules on MDCalc come from Canadian researchers. And we have to put them up on a pedestal and say, these guys are our heroes. And then we have to make ways for the clinician at the bedside to understand that and apply it at the bedside. That's the area I'm most interested in. And a lot of other folks can get involved. Payers can be more creative with how they create incentives driving us toward evidence-based care. And there's a little bit more in this space, and they could do a lot more here. And patients can make a big difference too. Instead of demanding, I need that head CT for my head trauma, I need the antibiotics. If you're not giving me something, I'm getting worse care. We need a culture that says, I want what's most evidence-based. I want a physician who understands evidence-based medicine and is patient-centered. And will make the decision, that's best for me. And hospital administrators, you guys love Kelso, also one of my favorite. I'm sorry you lost your grandmother, but that'll be $1,700. Hospital administrators can create protocols that are more evidence-based. And then who wins in this scenario and who loses? So patients definitely win, right? The better treatments, less side effects. Clinicians win because we can get better care to our patients. We can do it in a more organic way. What makes me feel like a physician isn't ordering a bunch of tests. It's doing a history and a physical, communicating with my patient. And now I can do that more because I can use clinical rules and tools to say, you don't need this treatment. I can reliably make decisions because of these types of tools. And it protects our liability because these things become the standard of care. Hospitals, they win. They can spend less money to take care of their patients. And when that pneumonia gets admitted, the insurance company can't say they shouldn't have been admitted if their PSI score says they did. And payers actually benefit because it costs less overall to take care of patients. And they avoid paying for inappropriate care if those scores are low. And I would argue most of innovation in pharma actually benefit too. Because when a drug does work, when an immunotherapy does work, we should be willing to pay for that because it's helping patients. And this improved trust issue is a big one. I speak to pharma audiences often, actually, and there's a big divide between pharma and physicians. We don't trust them because they're constantly selling us flashy ads. It's like going to Cairo and everyone's trying to sell you stuff, so you look down, you're like, get away from me, right? Physicians in this room, I think, know what we're talking about. If pharma is more focused on evidence and showing this works, this doesn't, that improves our trust. Who loses then? It's those providing inappropriate care, overpriced care, or the fraudulent, and I'm okay with that. So if this surface of the circle represents the $35 billion in foreign aid that we've been debating whether or not we should be spending, then the amount that I'm proposing we could save in healthcare is represented by this. And if we save that much money, how would we spend it? Well, I would say let's insure every American. The underinsured and the uninsured, that would cost about 20% of that. Let's triple the NIH budget, that would cost another 7%. What would that do for us, right? I'm running out of things to spend money on. All right, let's double the federal education budget. Let's triple the National Endowment of the Arts because Trump wants to eliminate it. That's a little sliver. I'm running out of things to so even if we're wrong about the $1 trillion idea, we can pay for a ton. We can stop having this debate if we follow evidence-based medicine. I'm going to end with 3 quotes from the Atlantic article I mentioned that I really like. The first is on bioplausibility. That's the concept that something seems like it should work. Those stents in the coronary arteries, it opens the flow. We can see the flow increase. Of course it should work, right? Chances are you or someone in your family has taken medication or undergone a procedure that is bioplausible but does not work. Speaking on the human body, humans didn't invent it. It's really complicated, and people often have remarkably little insight into cause and effect. I think about this a lot in medicine to keep me and my colleagues humble. And finally, medicine can be like wine. Expense is sometimes a false signal of quality. Thanks, guys. Oh, I wanted to mention one thing, MDCalc. It's this 12-year-old site that we run. A lot of times, I know there's a lot of residents and med students in the audience. We're setting up this new fellowship program where we found ways for residents and med students to be able to help and contribute to MDCalc. So it's a competitive program. It's 2 years during residency or fellowship. It's only a couple hours a week, and you get to help publish on MDCalc. If you're interested in that, email Rachel or I. Really easy emails, Rachel at MDCalc and Joe at MDCalc. Thanks so much.
Future of Care is New York City's premier community for healthcare innovation. To learn more, subscribe to our channel and visit our website at futureofcare.nyc.